Dear students, welcome to you all today's pathology session. I am Dr. Asma Hosna, Associate Professor, Department of Pathology, Bashundhara Ad-din Medical College. Today, I am going to discuss about the germ cell tumor of the ovary. In our previous class, I have already discussed about the teratoma. I am going to discuss today about dysgerminoma. The dysgerminoma is a malignant germ cell tumor of ovary. It accounts for 2% of all ovarian cancer and 50% of germ cell ovarian tumor. They may occur in childhood, but 75% cases it occur in second and third decades. When this dysgerminoma, that means the ovarian counterpart of the testis, it is known as seminoma, and the prognosis of the dysgerminoma is good. Now come to the gross examination. The dysgerminoma, they are solid tumor and that are ranging from small nodule to large mass. And the cut surface shows yellow white to grey pink color, soft and fleshy in nature. During microscopic examination, it is composed of large vesicular cells that have clear cytoplasm, well defined cell boundary and centrally placed regular nuclei. And the dysgerminoma cells are arranged in sheets or cords that are separated by thin fibrous septa. These fibrous septa are infiltrated by mature lymphocyte. Then what is yolk-sac tumor? It is a malignant germ cell tumor, and the yolk-sac tumor is also known as endodermal sinus tumor, and still it ranks as the second most common malignant ovarian tumor of germ cell origin. Like normal yolk-sac, in yolk-sac tumor, the tumor cell also elaborate alpha fetoprotein, and it is histologically characterized by presence of a glomerulus like structure that is composed of central blood vessels enveloped by tumor cells within a space that is also lined by tumor cells, and this structure is known as Schiller-Duval body. And there are also presence of intercellular or extracellular hyaline droplet. Then the metastatic tumor of ovary, it is commonly Kuchenberg tumor that are metastasized from the ovary of stomach, colon or intestine, and it is characterized by bilateral metastasis and composed of mucin producing signet ring cell cancer cell, and most commonly it is gastric in origin. What are the hormone producing tumor of the ovary? There are many hormone producing tumor. The granulosa cell tumor that produce estrogen, rarely androgen, the thecoma that produce estrogen, Sertoli-Leydig cell tumor, they produce androgen, rarely estrogen, Sertoli cell tumor, both androgen and estrogen are produced, carcinoid tumor, they produce serotonin, choriocarcinoma produced human chronic gonadotropic hormone, and gonadoblastoma, they can produce androgens. That all about the disease of the ovary. Now, dear student, come to our next topic, that is placental disease, that is gestational trophoblastic disease. The gestational trophoblastic disease constitute a spectrum of tumor and tumor like condition, and that is characterized by proliferation of pregnancy associated trophoblastic tissue of progressive malignant potential. They include 4 diseases, that is hydatidiform mole, invasive mole, choriocarcinoma and the placental site trophoblastic tumor. Now come, what is hydatidiform mole? The hydatidiform mole is characterized by the cystic swelling of chorionic villi that is accompanied by variable trophoblastic proliferation, and the vulnerable age groups are teenagers and 40 to 50 years of age. Clinically, the patient may present in 4th or 5th month of pregnancy with vaginal bleeding and with a uterus that is usually but not always larger than expected for the duration of the pregnancy. And the incidence is in USA 1 in 1000 to 2000 of pregnancy. This hydatidiform mole can classify into 2 categories on the basis of histologic, cytogenic and flow cytometric studies, and they are complete mole and partial mole. Now come to the pathogenesis of hydatidiform mole. In case of complete or classic hydatidiform mole, all or most of the villi are edematous and there is diffuse trophoblastic hyperplasia, and there results from fertilization of an egg that has lost its female chromosome. So, the genetic material is completely paternal derived. During cytogenical studies, we will see 90% have a 46XX diploid pattern and all are derived from sperm, and the remaining 10% of the fertilization of such an empty egg by 2 sperm, and in both type embryonic development does not occur. So, complete mole shows no fetal part, that is important. In case of complete mole, there is no fetal part. But in partial mole, some of the villi are edematous and other villi show minor changes, and the trophoblastic proliferation is focal, and the mole results from fertilization of an egg with 2 sperm. So, the karyotypic pattern is triploid pattern, that means 69XXY, and tetraploid pattern, that means 92XXXY, and fetal part also may be present. What are the difference between the complete mole and the partial mole? In karyotype, the complete mole may have 46XX, 46XY. In partial mole, it may be diploid. The villi are edematous in case of complete mole, but some villi are edematous in case of partial mole. And the trophoblastic proliferation is diffuse and circumferential in case of complete mole, but focal and slightly occur in case of partial mole. Cellular atypia usually absent in case of partial mole, and the beta HCG level is markedly elevated in complete mole, and due to behavior about 2% cases the complete mole may turn into choriocarcinoma, but in case of partial mole it is very much rare. Now come to the clinical significance of a hydatidiform mole. Some mole may turn into malignancy. 80 to 90% of this mole are benign, 10% may develop invasive mole, and 2.5% may turn into choriocarcinoma. During macroscopic examination, the uterine cavity is filled with delicate fibril mass of thin walled translucent cyst, and during gross examination we will find grape like structure, and there may be a small collapsed amniotic sac. Fetal parts are frequently seen in case of partial mole, but never seen in case of complete mole. And microscopic examination, in case of complete mole, there are presence of hydropic soiling of chorionic villi, avascular edematous and giant chorionic villi are seen, and there are proliferation of trophoblastic cell, both seen cytotrophoblast and cytotrophoblast. But in case of partial mole, there are presence of focal edema and focal and slight trophoblastic proliferation. During the biochemical examination or biochemical study, there are rises beta HCG level, and the pregnancy test is positive even in high dilution, 1:100 times or more dilution, the pregnancy test is positive. Then what is invasive mole? It is cystically dilatation of chorionic villi which penetrate the myometrium and sometimes lymphatics and blood vessels, accompanied by proliferation of both cytotrophoblast and syncytotrophoblast. It may pass to brain and lung, but do not grow in those organs as the true metastasis, so it is benign. Then come to our next topic, that is choriocarcinoma. It is a gestational choriocarcinoma is an epithelial malignant neoplasm of the trophoblastic cell that is derived from any form of the previously normal or abnormal pregnancy. That means it is derived from any form of previously normal or abnormal pregnancy. So, it is rapidly invasive, widely metastasized a malignant tumor, and this tumor can also secrete human chorionic gonadotrophic hormone. Clinically, the patient may present with irregular vaginal spotted bleeding or browny fluid, and the discharge may appear in the course of an apparently normal pregnancy or after a miscarriage or after curettage. It is preceded by some condition. In HYDATIDIFORM mole, there are chances 50% of the cases. If patient have previous abortion, it is 25% of the cases. In case of normal pregnancy, there is a chance of 22% of the cases, and the remainder occurs in ectopic pregnancy, genital and extragenital teratoma. It is 1 in 40 HYDATIDIFORM mole may give rise to choriocarcinoma, in contrast to 1 in 150,000 normal pregnancy. Now come to the gross examination. Grossly, the tumor is large, soft, yellowish white and fleshy with the areas of necrosis and hemorrhage. And histologically, it is consist of abnormal proliferation of cytotrophoblast and syncytotrophoblast, and the tumor invade the underlying endometrium, and there are absence of chorionic villi. Mitosis are abounded and sometimes abnormal. Hemorrhage and necrosis are common. This tumor can metastasize widely, and the favorable sites are lungs, 50% of the cases, also can metastasis to the vagina, brain, liver and kidney. And the gestational choriocarcinoma is highly chemosensitive, and cure can be achieved even with metastatic disease. This is all about, my dear student. Inshallah, see you again in our next class. Till then, Allah Hafiz.